I'm Dr. Fakir Raveri, and this is Influenza and Community-Acquired Pneumonia in Adults. Respiratory tract infections can be divided to upper respiratory tract infections and lower respiratory tract infections. Common cold, which is the most common upper respiratory tract infection, primarily affects the nasal cavity and the sinus area. Otitis, which is basically the infection of the ear, is also considered an upper respiratory tract infection. You can also have pharyngitis, which is the infection of the pharynx. Pharynx is, of course, the canal that connects the nose to the throat. And lastly, you can have rhinosinusitis, which is primarily the infection of the sinus cavity. We can also have lower respiratory tract infections. There is something called bronchitis. There is the left bronchus and the right bronchus that connect the trachea to the two lungs, and the inflammation of the bronchi will lead to bronchitis. And then there's influenza and pneumonia that can cause infection deeper into the lungs, leading to problems with oxygenation. And of course, you can have pulmonary tuberculosis, which we will discuss later. Now, let's take a look at pneumonia. Pneumonia is a form of acute respiratory tract infection that affects the lungs. When an individual has pneumonia, the alveoli in the lungs are filled with pus and fluid, which makes breathing painful and limits oxygen intake. In 1901, Sir William Osler noted in the 4th edition of his book, The Principles and Practice of Medicine, that the most widespread and fatal of all acute diseases, pneumonia, is now captain of the men of death. Over a century later, the prominence of pneumonia as a clinical entity remains. In fact, it remains among the top 10 most common causes of death, and it is the single most common cause of infection-related mortality. Now, let's take a look at the anatomy of the lungs. As you can see, there are two zones in the lungs. There is the conducting zone and there's the respiratory zone. The conducting zone basically consists of trachea, bronchi, and bronchioles. As you can see, as we go deeper into the lung, the number of branches increase. So when you get to the alveolar sacs, there is an extreme number of sacs, which is intended to increase the surface area in order to allow oxygenation of the blood. Now, when there's inflammation in the conducting zone, such as bronchitis, it becomes difficult because this area is inflamed, it becomes difficult for the air to go through, so it will be difficult and painful for the patient to breathe. Now, when we have a more severe infection such as pneumonia, there will be deeper into the respiratory zone. So now the patient will have respiratory issues. So there will be marked hypoxia in the patient. Now let's analyze the lung on a cellular level. Now I'd like to bring your attention to the structure of alveolar. So note that in the alveoli, there are type 1 epithelial cells and type 2 epithelial cells. And type 2 epithelial cells actually secrete surfactant, and surfactant has a crucial role in maintaining alveolar structure by reducing surface tension. And the reason it is important to know that these type 2 epithelial cells secrete surfactant is that surfactant can actually affect antibiotics. The most important antibiotic that's affected by surfactant is daptomycin. Daptomycin is completely deactivated by surfactant. So while daptomycin is an excellent antibiotic for treatment of MRSA infections, it should never be used for respiratory tract infections because by the time daptomycin gets to the alveoli, it will be deactivated by surfactant. So you should never ever use daptomycin for pneumonia. Now, vancomycin, linezolid, and ceftaroline are not affected by surfactant, and they are used for treatment of MRSA pneumonia. Now let's take a look at the pathophysiology of pneumonia. As I mentioned, there are two zones in the lower respiratory tract. There's the conducting zone and there's the respiratory zone, which is basically the lung parenchyma. Now the lung has a elaborate system of host defenses that when functioning properly, they actually are very effective in protecting against pathogen invasion of the lungs. Now, for the most part, infections in lower respiratory tract occurs in patients with impaired host defenses, usually due to genetic disorders or in compromised ciliary functions such as patients who smoke. It is important to note that all individuals are at risk for development of pneumonia. Now, some individuals have higher risk of getting pneumonia. There are different ways of getting pneumonia. Inhalation is the most common route. Inhalation of infectious particle is the primary route that leads to development of pneumonia. Aspiration of oral flora can also lead to pneumonia, which we call aspiration pneumonia. Now, note that this typically includes the flora in the mouth and possibly what's in the gastric content, but it's unlikely to include anything from anything past the stomach. So it's unlikely to include anything from the intestine. So bacteroides are extremely unlikely. There are also other possibilities of getting pneumonia. For example, if someone has bloodstream infection, because the blood goes to the lung where oxygen exchange occurs, that infected blood can actually infect pneumonia. You can also get pneumonia from invasive procedures such as intubation. Now, while these are possibilities, they are not as common. So the most common route of getting pneumonia is by inhalation. Now, let's take a look at chest radiograph, also known as chest X-ray. Now, when we look at the film in a normal chest radiograph, it's supposed to be clear. So generally speaking, it's clear. The lungs are clear. You can you can see the heart and you can see the diaphragm. Now, when there are things in the lung, what we see on the film is increased opacity, which we call infiltrate. Now, these infiltrates or increased opacities, which you will see in chest X-rays B and C, they could be due to different things. Some of the possibilities include water in the lung, which could be, so if you see water on the chest X-ray as infiltrate, it would be common in patients with heart failure who have fluid retention, patients with low albumin, for example. Cirrhotic patients also have fluid retention, so you will see these fluids as infiltrate on chest X-ray. The content can also be pus, which will be the case in pneumonia. So if the patient has pneumonia and there's pus in the lungs, you will see infiltrate on the chest X-ray. There could also be blood, which is the case in trauma. So if somebody has ruptured their lungs, there will be blood in the lungs, which will show as infiltrate. And of course, the infiltrates could be cells, which would be the case in cancer. So if there are cancer cells in the lungs, they will show as infiltrates. Now, there are different ways of describing infiltrates. Two of the common ones that you will encounter are patchy infiltrates and dense consolidation. So when, patchy infiltrate could be usually due to either presence of fluids or viral infections or atypical organisms. And when you have dense consolidation, as you can see in film C, dense consolidation is usually more likely to be due to non-atypical organisms such as gram-positive and gram-negative organisms. Now, keep in mind that the chest radiograph is just a tool to help with diagnosis. There's no way to know for sure what's causing the infiltrates. It's important to use chest X-ray with clinical judgment. Another thing that can show up as infiltrate is atelectasis, which is basically the collapse of areas of the lung. So that's also something that you will see frequently. Now let's take a look at influenza. Influenza is an acute febrile respiratory illness caused by the influenza viruses. In temperate climates such as the United States or North America in general, it typically occurs every winter. And it actually happens year-round in tropical climates. The flu season, for the most part, it's approximately between November to April in the US. Well, influenza has existed for at least the past 400 years. It was actually isolated in 1933. So the influenza A was the first that was discovered, followed by influenza B and C in 1939 and 1950. And then in 1936, we had a huge discovery that influenza virus could be grown in eggs, which gave us the ability to develop vaccines against influenza. Now let's take a look at influenza virology. The influenza virus is classified into three distinct types, which are called influenza A virus, influenza B virus, and influenza C virus. Influenza A virus can infect humans and other animals such as birds and swine, and it is the most severe and widespread disease. Influenza B can only infect humans, and it can cause severe disease, usually in elderly or high-risk patients. And influenza C can infect humans and swine, and it is rare cause of mild upper respiratory tract infections. So because it's a mild upper respiratory tract infection, there's typically no treatment. Patients will just naturally clear it. Now, both influenza A and B are subject to antigenic drift, which are basically point mutations that happen in the genetic material of the influenza virus, and this leads to variation that can cause epidemics every influenza season. Now, influenza A is also subject to antigenic shift. With antigenic shift, the variation is so much that actually a new strain of the virus is introduced, which can cause global pandemics. And this typically does not happen with influenza B. And of course, influenza C can infect year-round, unlike the seasonality of influenza A and B. Influenza virus is an enveloped negative sense single-stranded RNA with segmented genome, meaning that there are multiple RNAs inside the virus. Hemagglutinin, abbreviated H or HA, is a viral attachment protein, which you can see. So in this picture, I'm showing you influenza A specifically, and this is hemagglutinin. And there are at least 16 distinct hemagglutinins in influenza A. There's also neuraminidase, which is abbreviated N or NA. And neuraminidase is an enzyme that catalyzes the removal of terminal sialic acid from sialic acid containing glycoprotein. And I will explain what this actually means when I show you the life cycle of the virus. Another name for neuraminidase is sialidase. And the reason this is important to know, because we have a class of drugs called neuraminidase inhibitors, and sometimes they're referred to as sialidase inhibitors. And something that's specific to influenza A only is the M2 protein, which is basically an ion channel, which you can see here. This does not exist in influenza B. Now let's take a look at influenza nomenclature. So the standard nomenclature includes the influenza type, so it's either A, B, or C, and then they put in the name the place of initial isolation, followed by strain designation, year of isolation, and if in the case of influenza A, it also divided into subtypes on the basis of H and N. So for example, the influenza A virus that was isolated by Francis from a patient in Puerto Rico in 1934 is given the strain designation A, Puerto Rico, 834. And then a more recent example is the pandemic H1N1 influenza A virus first identified in April 2009 in a 10-year-old patient in California, which has the designation A/California/7/2009, and then in parentheses, because this is A, we have H1N1. In 1934 they didn't have the molecular capability to type H and N, so that's why the 34 from 1934 doesn't have it. But in modern era we have the molecular capability to type H and N. So this is the H1N1. Now let's take a look at influenza transmission. The influenza virus actually has the ability to spread very efficiently from person to person through three routes. So One route is by aerosol, which are basically the fine particles that remain airborne for minutes to hours, which basically comes from a donor or an infected patient, and they can be inhaled. And because they are so small and fine, they can actually go deep into the lung. And because they go deep into the lung, they can cause lower respiratory tract infection. They can also be in the form of droplets. So because droplets are large particles, they typically don't go too deep into the lungs. So if someone gets influenza by droplet, they end up having upper respiratory tract infection. And of course, by contact transmission from fomite. So fomite is an inanimate object that's been contaminated by the virus, and once there's contact with the mucosal surface, that's how patients get infected. And typically, because the virus can actually last up to 48 hours on these surfaces. Now, let's take a look at reliable resources for lower respiratory tract infection. Infectious Diseases Society of America and the American Thoracic Society developed most of the guidelines for lower respiratory tract infection. The first guideline is the 2005 ATS-IDSA guidelines for the management of adults with hospital-acquired ventilator-associated and healthcare-associated pneumonia. This guideline is particularly useful if you need information about healthcare-associated pneumonia. There's also the 2007 IDSA ATS guidelines on the management of community-acquired pneumonia in adults. Now, there was a 2009 IDSA guidelines for seasonal influenza in adults and children, but this guideline is no longer used because it's outdated. Instead, we use the 2011 CDC guidelines for antiviral agents for the treatment and chemoprophylaxis of influenza. There's also the 2016 IDSA ATS guidelines for management of adults with hospital-acquired and ventilator-associated pneumonia. There is also the 2018 IDSA guidelines on seasonal influenza that was recently published. Now, in October of 2019, after 12 long years, IDSA and AST together developed updated guidelines for community-acquired pneumonia, which borrows some components from the 2007 guidelines. We will discuss those shortly. The first learning objective is describe the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. Now, when we look at the life cycle of influenza virus, it's important to know that endothelial cells of the host have receptors that are rich in sialic acid. So hemagglutinin on the envelope of the virus will actually bind to those sialic acid containing receptors. Once bound to the host cell, the virus will enter the cell through endocytosis, and as the pH drops inside the cell, the RNA material will be released into the cell, as shown in orange, these orange bars. Now, as I mentioned earlier, the influenza virus is actually a negative sense RNA, and that means that a negative sense RNA is not ready to just find a ribosome and translate into protein. What it needs to do is to first translate into positive sense RNA, and then a positive sense RNA will be ready to find a ribosome and translate into protein. So what these negative sense RNAs need to do is to enter the cell, and then using the RNA-dependent RNA polymerase, make a replica of these negative sense RNA, which are shown as blue bars, and those blue bars will actually be positive sense RNAs. Now, this process is extremely important to the life cycle of the virus, and we have drugs that can actually target the RNA polymerase. So we have ribavirin that is actually an RNA polymerase inhibitor, but it's not commonly used for influenza. And we have a new drug called baloxavir. Baloxavir is an endonuclease inhibitor, so it selectively inhibits the cap-dependent endonuclease activity of the influenza RNA polymerase. So by inhibiting this RNA polymerase, it results in inhibition of mRNA synthesis, so it will interrupt the the life cycle of the virus. Once the mRNA is synthesized, it will go to find a ribosome and translate into protein. And those protein products, along with some of these mRNAs and some of the, the RNA material of the virus, will basically assemble into a virus. The final step is the release of the mature virus. And because, again, this hemagglutinin is bound to the cell receptor through sialic acid binds, it actually needs sialidase, or another name for it is neuraminidase, to actually cleave that bind to let go of the virus. So because that sialidase or neuraminidase is extremely important for the final step of releasing the mature virus from the host cell, we have a class of drugs called neuraminidase inhibitors, such as oseltamivir and zanamivir, which actually prevent the release of newly synthesized virus from the host cell by inhibiting sialidase or neuraminidase. Now, we currently have 3 drugs on the market under neuraminidase inhibitor class. So the first one, which is the most commonly used, is oseltamivir phosphate. So it's a prodrug. That's why you see phosphate in the name. The brand name is Tamiflu. It's available as a capsule and in suspension form. And for treatment of influenza, we typically use 75 milligram PO twice a day for 5 days. You can also use it for chemoprophylaxis for preventing influenza. Note that the dose is just once a day, but for 10 days. And it is renally cleared, so the dose needs to be adjusted if the creatinine clearance is less than 60. It is pregnancy category C. However, Tamiflu, or I should say oseltamivir, is preferred in pregnancy because it has relatively more data compared to the other drugs in this class. The second one is zanamivir or Relinza, which is actually an inhalation. I have posted a video for on how to administer these inhalations, and I encourage you to watch this video. One thing that's especially important about Relinza is that it actually has lactose in it, so it's contraindicated in patients who have allergy to milk protein or lactose. Also, because it is inhalation, the systemic absorption is minimal, so there's no dose adjustment needed. The last drug in this class is Pramivir, which is actually an intravenous formulation, which you can just give it once. Now, the most common adverse effect with all of these is basic gastrointestinal, such as diarrhea, nausea, and vomiting. Oseltamivir can also cause headache, and of course, zanamivir is inhalation, so it can cause bronchospasm. And then, of course, baloxavir marboxil is newly approved. It's also a prodrug. It's an oral formulation. Note that it's dosed based on body weight, and there's no dosage adjustment needed for it. It can also cause gastrointestinal adverse effects, as well as headache and bronchitis. One thing that's special about baloxavir is that it's active against oseltamivir resistant strains and avian strains of influenza.